terms of substitute decision-making, and it's very clear, of course, when we're talking about advanced directives, and that's one thing we did, I think, well as well in BC. Our advanced directive legislation, which is part of the Healthcare Consent and Care Facility Admission Act, talks about an advanced decision. It doesn't talk in other provinces, it talks about wishes. No, it may be not a good decision, it may be a foolish decision, but we shouldn't talk about wishes because that's too, well, we don't know what you have to do with wishes. It's very clear from our legislation that an advanced decision either to give consent in advance or to refuse in advance. And that's based, of course, on the principle of autonomy, which is what the Canadian Charter of Rights and Freedoms, our Constitution, is all about. And it is very clear, despite the fact that possibly the judge in the Bentley case, I'm not sure whether he said this. He was urged by some of the defendants to say this, that there are certain things that a capable person cannot refuse, but that's wrong. Sorry, Judge, you're wrong, if that's what you said. A person is entitled to refuse anything that keeps them alive. Advanced directives, you see here, can consent or refuse. Refusal must be complied with. Does consent always have to be to comply with? By the way, the advanced directive only applies to healthcare. So personal care, whatever exactly that means in British Columbia, you were not sure, but that you can't put in an advanced directive. It's only healthcare narrowly defined. Substitute decision-making, where there is no advanced directive. Again, we're not sure whether that includes personal care for a representation agreement, which is the proxy directive that Dr. Kenny talks about. The representation agreement, you can refuse personal care, and there is since 2011 a definition of personal care in the Representation Agreement Act. Is it a good definition? Well, it's a definition. I don't think it's terribly good. For one thing, it includes diet, and that led the judge in the Bentley case to say, well, that means any kind of feeding, any kind of nourishment. No. Rob and I wrote that legislation, Rob Gordon and I did, and with diet we meant, do you like meat or fish? Are you a vegetarian or a meat eater? It doesn't mean feeding as such, it doesn't mean nutrition as such, but that's how the judge interpreted this. Now, unfortunately, we have different standards for substitute decision-making depending on the legislation we're dealing with, and that's bad news. That's totally confusing. I've had professionally, I've been asked to review some of the most policies, and they failed to take into account the difference between the duties of the various decision makers. A committee of person under the Patients Property Act, even though the Act itself is silent on it, but the courts have said that person has custody of the individual and must act in the best interest, despite the fact that ethically you try to put yourself in the shoes of this person. Legally, you must act in the person's best interests. That changes radically when we talk about representation agreement, much more complex. You have to comply with current wishes of the person, despite the fact that they may be incapable, unless the agreement specifically says, don't ask me at the time, just make the decision. And if you ask for current wishes, and even if those are completely different from what's in the representation agreement, you have to comply with it, with those wishes, if it is reasonable to do so. Does the legislation say what is reasonable? No, of course not, because we're all assumed to act reasonably, right? So if there are no current wishes or they're not reasonable, then the representative has to comply with previously expressed, while the person was capable, instructions or wishes. None of those, The representative must comply with the known beliefs and values, very difficult to do in most cases, and you don't know about the beliefs or values, you act in the best interests. Now, it would make sense if for the TSDM, the family member or good friend who's going to make decisions for you, it would be the same decision-making framework. No, it isn't. To the extent possible, you must consult with the adult, but only consult. You don't have to do what they say. Then you must follow previously expressed capable instructions or wishes. Where do the values and beliefs end up? Since 2011, they are in best interests, which I think is probably a good idea. So when you decide whether something is in the person's best interests, then you look at what their beliefs and values are. And I'm being looked at, and we do want in other words, that's the only other thing I'm going to say. The best interests approach looks at what the person's values and beliefs are, but they're not the end of the decision making. In the end, it is the person who is the substitute decision maker that overall looks at what the person's beliefs and values are and how much of an impact, how cumbersome the treatment is going to be, what the likely outcome is, and so on. We do have, and I think we're the only province in Canada, a specific provision regarding end-of-life decisions, and that was used by the judge in the Bentley case, wrongly, but it was used by the judge in terms of concluding what, in addition to the substitute decision maker's decision, what is required. Because in end-of-life care in BC, it's not just that decision-making tree that we talked about. In addition to that, the decision must be medically appropriate in the view of the healthcare providers. Very few people know, I'm not even sure Rob knows, that my initial draft said the attending physician decided whether something was medically appropriate. And because the BCMA and the College of Physicians and Surgeons didn't like what I had written next, which was that the doctor had to consult the senior nurse involved in the care of the individual. The doctors didn't like that at all. So we ended up with substantial agreement among the healthcare providers. But who are these people? I think in Bentley, it was the care team in the facility, care aides most likely, who trumped the view of the attending physician, which I think is bad news. But I'm sure there are all kinds of questions about that, and I'm going to stop here.
In my slides on advanced care planning, intrinsic issues in pre-commitment, I said exactly what Gerrit said. You see the issue, there's ethical reflection about this. The problem of protecting futures, that is, a person gives you the decision and it's a decision. I want you to refuse this or do this. And then look at the question, can a prior commitment undermine best interest in the present circumstance? So I didn't realize Gerrit was going to say what he did the way he did, but that's the problem.
Right.
It isn't that we don't respect what the person said, but to take it as absolute positive truth when the person now acting for the patient is in a different set of, the situation is always different at the time.
No,
so it's not disrespecting it, but if you ask the question, sometimes this, the way I put it, because that's the way it is now in the ethical reflection, is about best interest and the substitute decision maker having to try to act for best interest. Just thought it was an interesting convergence when you said that.
I should add very briefly to that we have certain safeguards in the legislation so that if it is clear that a person had changed their mind but never gotten around to changing the advance directive, then the advance directive must not be complied with. If the instructions don't address the issue, it must not be complied with. So there are certain safeguards to come to what may be more of a best interest approach as opposed to something that doesn't fit the circumstances.